Keynote 522, pembrolizumab in early triple negative breast cancer. 5 is red because you can remember overall survival difference is 5% at 5 years. Right. What is Keynote 522 in one slide? It's a randomized controlled trial, two arms. One arm had 8 cycles of pembro with NACT, followed by surgery, followed by 9 cycles of pembro maintenance, versus 8 cycles of NACT followed by surgery. Remember, there was no adjuvant systemic therapy in the control arm, right? What is the result? It statistically significantly improves pathological complete response, event-free survival, and overall survival. The table shows the values. What you can roughly note is 5, 10, 15. The amount of OS difference at 5 years is 5%. The EFS benefit, the difference that you get is 10%. And the pathological complete response difference is 15%. Right. So, starting with pathological complete response, all the three were published in NEJM in 2020, 2022, and 2024. The comments were highest pathological complete response in TNBC ever, impressive event-free survival, and a consistent overall survival in early cancers like kidney, lung, cervix, and breast. Right. What are the inclusion criteria? Of course, early breast cancer, triple negative, stage 2, 3. A simplified inclusion is a T size more than 2 centimeters or node positive disease, either one or both. Also included were bilateral breast cancer, multifocal disease, inflammatory breast cancer, which are usually excluded, but here it's included. Well, if you look into the baseline characteristics, T1-2 tumors were 75%, node positive were 50%, and the CPS was positive, like PDL1 was in 80% of patients. Right. What was the chemotherapy used? Remember, it was paclitaxel carboplatin first. It was 80 per meter square and AUC 1.5 weekly for 12, or 3 weekly 175 per meter square and AUC 5 into 4, followed by ECR-AC 3 weekly into 4, followed by surgery. Pembro was 3 weekly 200, 8 cycles in neoadjuvant and 9 cycles in adjuvant. Right. What is the important point to note here? We usually use anthra followed by taxanes, but in this trial, it was pacli carbo first, and then came anthra. And the dose of carbo here is not AUC 2 weekly, it is 1.5 weekly, and weekly pacli carbo was used in 60% of the patients. Right. What about adjuvant capecitabine? Because we all know, based on the Createx adjuvant cape in triple negative, those who did not have pathological complete response improved overall survival. However, it was not allowed in this trial. The reason being, the trial was designed before Createx was reported. The Createx was published on June 1st, 2017. Keynote 522 started from March 2017 to September 2018. But still, an amendment could have been done. But the reason is, it was not yet, the Createx was not yet accepted as standard of care in all countries. Therefore, the control arm or any of the arms did not receive adjuvant capecitabine. Leave olaparib. The Olympia was reported later. Therefore, capecitabine or olaparib was not used in this particular trial, and it was not allowed. Right. What are the endpoints? Primary, pathological complete response and event-free survival, and secondary is overall survival. The other secondary endpoints are in the CPS positive patients. Right. This is the definition of EFS: either disease progression precluding surgery, local or distant recurrence, second primary cancer, or death from any cause. So we already saw the results. Remember, 5, 10, 15. 5% OS, 10% EFS, and 15% pathological complete response and difference in between the control and the pembro arm. Right. The question is the overall survival benefit still valid in the present era of capecitabine and olaparib? Well, just look into the curves. So the question is because the control arm did not receive any adjuvant therapy, adjuvant systemic therapy, adjuvant RT was given, right? So look into the pathological complete response group. Those patients who had pathological complete response had a overall survival that is 95.1, 94. There is hardly any difference. And that group which did not have the pathological complete response had a 6.1% difference in the overall survival. So, well, if you look into Createx, it had similar patients of no PAT-CR. It had an absolute difference in OS of 8.5%, and olaparib had nearly 3.4% difference in overall survival. So, if the control arm, in that subset which did not receive uh, pembro, if you could have given adjuvant capecitabine or olaparib, probably the overall survival difference would not have been there, right? So, well, which Paclitaxel is better, weekly or 3 weekly? Definitely, the pathological complete response and event-free survival are far better in the weekly arm than in the 3 weekly. However, there is no significant difference in overall survival. Then, who benefits more with pembro? Those with pathological complete response or no PCR? Well, in the PCR group, there is no benefit as we already saw. Then why non-PCR group benefited? These are the points that they mention in the paper. There may be less residual disease, even in those patients who did not have PAT-CR. Pembrolizumab probably changes the disease biology, and maybe adjuvant pembro would have helped. So you can clearly see the 5-year OS is not different in the PCR group, and in the no PCR group, there is a 6.1% difference. Well, if you have achieved a complete pathological response with whatever new adjuvant therapy, can we omit pembrolizumab? Maybe, we do not know. The trial was not designed to answer the differential benefit of neoadjuvant or adjuvant therapies. Right. Who benefits more? Is it PDL1 positive or negative? Remember, 80% were CPS positive in this trial. Very important what you can note in the first left table is the CPS positive group, whatever you gave pembro chemo or chemo alone, the pathological complete responses were higher in the CPS positive group than the CPS negative. That means CPS positive inherently is good. It has a better pathological complete response and a better EFS. This is what you need to remember. But the absolute numbers are higher in the CPS positive, but the delta, the difference pembro chemo causes is greater in the CPS negative patients. So pembro chemo works in both the subgroups, but the delta of benefit is more in the CPS negative subgroup. The reason being CPS negative has a bad outcome. On that, you can create a delta. Whereas CPS, the PDL1 positive cases show better responses than PDL1 negative, making it challenging to enhance on those improved outcomes. It is something similar to platinum in BRCA mutant, EBC, because platinum did not show that benefit in BRCA mutant versus BRCA negative. The reasons are PDL1 probably is a dynamic marker, and it may be heterogeneous in the primary versus micrometastasis. Right. This is important. Residual cancer burden and the event-free survival. So what about that big group who did not attain pathological complete response? That we will see. So you have RCB 0, 1, 2, 3. 0 means complete pathological response, no disease. This happened in nearly 60% patients, as you saw. Though 1 is minimal residual disease, was there in only 10% patients. 2 is moderate residual disease in 20% patients. And 3 is extensive disease, is nearly 5 to 10% patients. What you have to remember is that difference in event-free survival was not seen with RCB 0 or RCB 1. It was seen only with RCB 2, where you had moderate residual disease, which benefited only 20% of patients. And importantly, note the RCB3 where there was gross or extensive residual disease, giving Pembro was detrimental. So the 3 points to note are no difference in RCB 0 or 1 in 70% patients. And in 20% patients, there was the most pronounced benefit of 20% difference in EFS, and it is detrimental in RCB3, that is 10% patients. Right. So the benefit of the whole population is basically driven by this 20% of RCB2, right? Is there a differential overall survival benefit for T and N? Yes. So smaller size tumors have a better hazard ratio than a larger size tumor. T3, T4 were 25%. The hazard ratio was not that impressive. It is 0.88. Whereas node positive and negative, they had similar hazard ratio for overall survival. What about age? Because in the TMH Pacley Carbo study, the platinum was beneficial in less than 50 years of age. What about Keynote 522? 10% of patients were above 65 years. The hazard ratio for OS is marginal, it's 0.96. Right. In what percentage of patients was there a disease progression before surgery during neoadjuvant chemoimmuno itself? Well, 7.4 versus 11.8 with a good hazard ratio. Therefore, the chances of disease progression on NACT is less if you add Pembro to NACT. Right. So, what percentage of patients who finished NACT surgery went on to receive adjuvant Pembro? Only 75%. The remaining 25% did not receive Pembro because of toxicities during neoadjuvant therapy. Right. This is important. In those patients who are on follow-up after treatment, what is important is in the RCB 0 and 1 group that consists of 70% patients, the first event was a CNS metastasis because of less bioavailability of chemoimmuno in the brain. Whereas in the RCB2, which was 20%, there it was more of a systemic recurrence because of resistance. And whereas in the RCB3, it was more of a local recurrence because of an immunosuppressive milieu locally. So the take-home message is those with pathological complete response or a very good response, watch for CNS as the first site of recurrence. Those with poor response to Pembro NACT, that is RCB3, they may not benefit with adjuvant, and local progression is what happens with RCB3, right? What was the post-recurrence treatment? No data yet, and no crossover was allowed post-recurrence. Can we expect more mature overall survival in future? The answer is no, because already a statistically significant improvement in OS is observed. The authors have said that there will be no formal testing of overall survival will be performed at later analysis. Well, three common questions. Can we combine pembrolizumab with capecitabine if there is no pathological complete response? Yes, because there is no overlapping toxicity. Can we combine pembro with olaparib if no pathological complete response and germline BRCA mutation positive? Yes, again, there is no overlapping toxicity, therefore you can combine. But if you can you add pembro in the adjuvant setting if I have not given in the neoadjuvant or if I have not given any neoadjuvant therapy? The answer is no. Right. So what are the conclusions? There is a significant improvement in OS, EFS, and PCR. Remember 5, 10, 15% as the values. Simple inclusion criteria is T size more than 2 centimeters or any node positive. Weekly Pacley Carbo has higher pathological complete response and event-free survival. Remember, Pacley was given first and then Anthra. Adjuvant CAPE and olaparib was not used in the trial. Pathological complete response group had no OS difference, may omit adjuvant pembro in these patients. PDL1 positive, higher pathological complete response in EFS was seen, but the difference is greater in the CPS or PDL1 negative subgroup. RCB01, no benefit with pembro. RCB2, there is a definite benefit of 20% difference in EFS. RCB3, detrimental. So only 20% of the patients of the whole lot of early TNBC have a significant benefit with pembro. T34 and age more than 65 had marginal benefit. Only 75% would start adjuvant pembro because of toxicities in the neoadjuvant setting. No crossover to pembro after recurrence was allowed. No further OS would be reported. Can combine pembro with CAPE or OLA in the adjuvant setting. Remember, these subgroup analyses were not powered, but this is what we can take off from the trial. Thanks again. Yeah.